There are a number of reasons why we're having these shortages. The drug supply chain is complex. There's a number of factors involved, and there's not really one pure identified reason that we're having these shortages. One of the reasons is that there's quality issues in a lot of the generic manufacturing plants. So the types of drugs, by and large, that we're seeing on shortage are generic injectables, drugs that we commonly use in our intensive care units, like sedatives, analgesics, anticonvulsants, very critical to what we do on a day-to-day basis. Many of these plants are having quality issues. Some have had to shut down whole production lines, which has caused very long-term shortages of some of these fundamental agents that we use. In addition to that, there's the complicated regulatory factors as well, and economic factors in addition to that. And these sort of all interplay together as part of our complex supply chain. In terms of general management strategies, there's a few things that departments of pharmacy and hospitals really should spend some time thinking about what their process is. And my guess is most folks have done this because you're sort of having to live with it, but you do need a very sort of structured process for how you monitor. I mean, the first step is just identifying that there's a problem. And so hospitals need to have a process to try to stay on top of shortages, and when they think one might be coming, trying to identify basically how much drug do they have on hand, and doing that sort of initial operational assessment is critical, because you don't want to find yourself in a situation where it's a Friday afternoon and you're running out of sodium bicarbonate, and by the way, there's only 5 vials left going into the weekend. That's not the time to identify those. So having a process to find the drug shortage, number one. Number two, identify how much drug do you have on hand, and then doing that therapeutic assessment. I mean, right now in 2012, the number of new shortages went down. We went from about 260 new shortages in 2011 to about 204 in 2012. However, all those old shortages aren't coming off the list. In other words, all the old shortages aren't back yet. So as I sit here right now at the end of December, we're looking at a number of active drug shortages of about 300, which is the highest it's been. And so the problem is going to persist. So you have to have a good internal process, a good team of people, a multi-professional group that's going to sort of try to track, plan, and implement and communicate these plans throughout the institution, because the big impact here is patient safety. Patients have been hurt by drug shortages. There's lots of documentation out there of good examples of medication errors where folks have been used to one drug and now have to use another. And there's examples where just the best agent is not available, or you're having to use agents with higher adverse effects.
One of the common shortages that we've experienced is of the analgesic class, and we've been fortunate to conserve our supply to the point where we haven't had to use agents that are less familiar. But for example, remifentanil is an agent that we potentially considered using if we were to run out of our first line agents in our ICU specifically. And the implication there is that although this is a drug commonly used in other settings, such as the OR setting, it's not necessarily something that all ICU clinicians are familiar with. So from a safety perspective, there's a need to educate prescribers, nurses, pharmacists, members of the multi-professional team about dosing of this agent, making sure it's in our smart pumps to ensure safety. The propofol shortage is a shortage we're currently experiencing. This actually is not the first time we've experienced it, so it's been easier to implement our strategy. When we first experienced it, we developed a conservative use strategy where we restricted it to patients where we felt could benefit from it most. For example, those with traumatic brain injury and elevated intracranial pressure. The loop diuretics, we took a bit of a different approach. While we did implement a conservative use strategy, in this case we had oral agents that were available. The IV furosemide is what the specific shortage was. And so our goals were to provide practitioners with alternative agents, comparative equivalency dosing information, so they could effectively and safely dose those alternative agents, which many may be unfamiliar with if they're used to primarily using IV furosemide.